I will show you a few cases just in order to say that for many physicians, especially many surgeons, the breast is considered of low-level interest and low-level difficulties. It's not true. Only for surgery, not only for surgery, but also for diagnosis and management. This you can see here, group of microclassification. It's better visualized here, yeah. And the follow-up examination by ultrasound, no evidence of lesions. The lady received the VAB procedure. The diagnosis was Giassas. The breast unit had proposal central quadrantectomy without any other imaging. Central quadrantectomy has been used for many times from a group, especially in Italy. But there is a question. We had greater number of recurrence after. In Italy, I don't know in other part of Europe, has been created a lot of breast unit, giving responsibility to people that has no great experience in breast diseases. It's just for have some people in charge of this unit, but without a real competence in this special field. So the people ask the second question. And second opinion, give a new ultrasound examination. You can see here the tract of the VAB. You can see here small lesion in anti-radial scan in superficial layer. You can see here another in deeper layer of the tissue at 9:30 o'clock, not a small lesion, and here other tissue alteration of the tissue. It's a suspect, it's not clear, and because there was a great difference in surgical proposal from the previous central quadrantectomy and second skin sparing mastectomy with immediate reconstruction, we performed magnetic resonance imaging. Magnetic resonance imaging gave this report with a diagnosis of multifocal. This is the residual, this is the residual after core, here, this residual core. The diagnosis was ACR by RAD6. So the patient performed not central quadrantectomy, but mastectomy with immediate reconstruction, and the diagnosis final was multifocal Giassas. It means that preliminary diagnosis was correct, but not enough, because it's not a simple lesion, but there was also some other lesion. But also, that was not correct ultrasound, because there is possibility to visualize small lesion if you perform a real whole ultrasound examination with good equipment, with a good experience, and with time gain compensation adequate for this type of breast, this type of technology. Another case is mammography, fine sclerosis in the right upper quadrant, yeah, in 25 of July. In 28th of July, mammography plus ultrasound, banding of a broad tissue in the right upper quadrant. The ultrasound doesn't show nodular lesion. No lesion for ultrasound. To be examined on March 2012. There is nothing. We're looking at these images, I have some doubt. 40 days later, the lady performed again mammography, new with another mammographer, another radiologist, dense area with speculations in the right upper quadrant to be verified by ultrasound guided biopsy. Ultrasound showed this lesion with increased vascularity also, here the lesion, very well visualized by three-dimensional reconstruction of the lesion with also microclassification inside. Yeah, with a normal double B scan in anti-radial scan and the section plan of from 9:30 to 10:30. The core biopsy was ductal invasive carcinoma plus DCAS. Dimension was 7.9 mm, 8 mm for 10. Specimen of ultrasound examination, final histology, invasive ductal carcinoma plus DCAS, cribriform, papillary, and solid of a lesion of 7 for 10 millimeters. Is the same of the ultrasound, and ultrasound before was not visible. What means that many people play ultrasound, not use ultrasound. This is very important. Just another case, because not only for diagnosis, but we can make also a mistake for surgery. Double residual tumor after lumpectomy in January 2017. 11 months later in axillary tail. Previous sector of inferior outer quadrant in May 2011. Yes, 2011. But it's totally different from this position. Here, there are clips for radiotherapy. And there was false negative. There is nothing in this axillary tail here. In March of 2016, it's a real false negative. It's a right. November 16, also negative. But maybe here it's not appropriate exposition of the breast because it's not the axillary tail. There's a technical failure. Here, in November, another. Here we can have a different projection. You have a lesion here. And in December 2017, 11 months after quadrantectomy cannot measure 7 centimeters. It's not quadrantectomy, 7 centimeters of in big breast of tissue. It's a lumpectomy. It's totally different. Here, there is another lesion. And ultrasound is this lesion. It's another measurement. Another. And also another different lesion in deeper layer of the tissue. The distance is very, very small between each other, but are two different lesions. And also there was another lesion here. 3 lesions after 11 months. So what means that surgery was not appropriate, because after 11 months it's not recurrence, it's a residual tumor because of inadequate surgery. It's a lymph node, and it's the inferior outer quadrant at 4 o'clock, where we make a reconstruction 6 years in advance. I stop here. Breast is a very hard task for every physician, for every technology, for every doctor. Please be careful when we have breast in front of us. The breast has the most number of type of cancer, most number of type of benign lesion. There is any other organs in our body that has this number of lesion of different biology. be careful. We must always start anatomy, pathology, imaging, and surgery. Not imaging directly. If you don't know pathology and anatomy, it's better don't start to play any type of imaging technology. Otherwise, it's dangerous for the women. And also for the physician today, because the medical legal litigation are very, very increasing. Thank you for your attention.
She's a 35-year-old woman that comes to breast clinic. She is already diagnosed with breast cancer, and she has undergone a breast conserving surgery 3 weeks ago. Her history has, she had a breast lump on the right breast of 12 o'clock localization. Her examination, she relieved a stiff fixed mass of 1 centimeter in size. Her axillary palpation showed 1 palpable lymph node. The breast ultrasound, she had breast ultrasound only, a 9 millimeter irregular mass with blatant borders, 2 suspicious lymph nodes in the right axilla. Her surgeon planned a breast conserving surgery at the time with the approval of the lesion by per-op frozen section histopathology. She didn't have a biopsy before the surgery. The per-op histopathology showed invasive ductal cancer. So she had the excision of this 1 centimeter, it was 12 millimeters of the pathology lesion, and she had the axillary dissection. So I would like to start with Dina. Do you think something is, oh, hello, welcome. Would you think her radiological diagnostic workup is good? She's 35, that's why they didn't do mammogram, they did only ultrasound. The microphone, please. Yes.
I would say initially you mentioned she didn't have any sampling of the lump that was removed before.
No, she didn't have any sampling of the lump. She had only ultrasound examination. What would you do if you were the radiologist of this girl or lady?
Well, she's 35. I would do full imaging. I would do ultrasound and mammogram and biopsy, depending on the breast density. If it's dense,
35,
and I would
dense,
expect this to be dense. Probably MRI as well, if that reveals some malignancy. A proper axillary investigation as well, just to avoid the case that there might be multifocal disease or multicentric disease, and to really make sure that she's getting the best care we can provide. Yeah,
so she may have multifocal disease or multicentric disease. That's why you do the mammogram plus MRI because of the density. So, and you would do the core biopsy of the lesion as well. Would you do the axilla?
Ultrasound or biopsy?
Axilla is positive on ultrasound. So would you do the biopsy of axilla?
I would, well, in my hospital, we have a very good cytologist, and we are really proud of their work. So I would go with FNA, and depending on the features seen on imaging, if my level of suspicious would be way too high and they would say it's benign, I would go to biopsy. But if they're confirming with FNA that nodes are normal, I would just go with FNA.
Okay. Yeah. So for the pathologist, I have a question. Do you know the case? You came late, but did you get the case? Yeah, she had a per-op a frozen section histopathology. She didn't have core biopsy before the surgery. So what do you think about per-op histopathology? Is it right, or would you prefer, or? Yeah, you should push the button. Yeah.
Well, I practice in the United States, which is a little bit different from the way they practice in Europe in terms of frozens in breast lesions. So I have pretty minimal experience on frozen sections in breast tissue. We don't do a lot of frozen sections in the US. It's very hard to interpret. If there's a lot of fat, it's very hard to cut. You may get a lot of false negative. So if you ask my opinion, I would say that with a pre-op biopsy would be the way to go rather than do a frozen.
Yeah, okay, thank you. So she had axillary dissection at the time of surgery after 1/3 positive sentinel node biopsy. Her surgical margins were clear. So I have a question for this surgeon. If it's 1/3 positive sentinel lymph node biopsy, and if the surgical margins of the tumor is clear, would you do the dissection, or would you just leave the patient for the like the Z11 or?
If a lady has a small tumor which can be removed via conservative procedure, and she's going to receive post-operative radiotherapy and some type of adjuvant treatment afterwards, she just have 1 or 2 positive sentinel lymph nodes and a negative axilla. Otherwise, she doesn't need to have a completion. This is very well established lymphadenectomy. This is very well established, and so that is probably.
So you wouldn't do the axillary
unnecessary morbidity, because it has been shown that the overall survival and the disease-free survival are the same. Plus, I mean, if there is a recurrence nowadays, it's also possible to treat it with radiotherapy.
Okay, thank you. And so, can you interpret the histopathology of her histopathology result, please?
It's like a pretty straightforward invasive ductal DLPR HER2 plus 2. Probably would proceed with FISH. HER2, I guess, is immunohistochemistry, I would imagine.
Mm-hmm.
Yeah, we probably would have proceeded with FISH to confirm that result. And
the FISH result was negative at the end. Yeah.
Oh, it was negative. Okay, interesting.
It's a very high Q6.
Yeah, the Q6 is very high. So.
Okay. So we preferred to. She came for chemotherapy afterwards. This operation to our unit, and we preferred to do the MRI after operation because we didn't believe we find out that she didn't have proper preoperative radiological examination or workup. So we preferred to do MRI and to see if the rest of the breast tissue was normal. As Dinah said, it may be multifocal because she's young, multicentric, so she needs MRI. So with MRI, would it be easy for you to interpret because you don't know? But you can interpret the images here. It looks like
there are some foci enhancing, and obviously on the bottom image, I would say the appearances are quite worrying. So, how long the MRI was done after surgery?
It's 1 or 2 weeks after.
Okay. So, yeah, well, I would be worried. I would go for assessment of the second look ultrasound probably.
Yeah. So she had multiple lesions. So we prefer to do. So if you have multiple lesions, do you do biopsy to all of them or some of them? Because it's the heterogeneity of the breast. Do you prefer to do one only to do big one or large one, or you do prefer 2 different type of lesions? Do you do 2, 4, 3 other biopsies?
We always discuss these cases in multidisciplinary team meetings, and if there's a question about the breast sparing surgery, we would sample each and every bit we're worried about. Sometimes we do the most furthest bits, so the lesions which are most far apart, because that would give us an extent, especially if there's something in the middle. So in that case, surgeons would rather go with mastectomy. But I must say, we have an excellent oncoplastic surgeons team, and they are doing really big tumors with oncoplastic surgeries with very good results. But I think we would sample each and every bit if we are worried about.
Yeah, okay. You know, sometimes there are a lot of lesions, so it's not possible to do them all, but we prefer to do the different ones.
Yes.
Yeah. So we did two different. She has more than 3 new lesions, other than the surgical side. It was far from the surgical side, and so we did a biopsy of 2 of them, and they were also malignant. So I would like to ask to medical oncology, if she was your patient and she was shown that she had multiple breast, multiple lesions, multicentric breast cancer, and it was a luminal B. And so with an axillary proven lymph node, would you do the chemo first, or would you do a neoadjuvant chemotherapy, or would you prefer the surgery first?
Okay, I might introduce myself. My name is Giassas, I'm a medical oncologist here in the Giassas hospital. Yes, for a laminal B, I prefer to go with surgery first and then give adjuvant chemotherapy. The reasons that we give neoadjuvant chemotherapy is because we have a table that shows us that we got a HER2 positive disease or triple negative disease, and they will have a benefit from neoadjuvant chemotherapy, or because we want to shrinkage the disease and make easier the things for the surgeon.
So you would prefer
I
surgery?
prefer, in this case, with the laminal B disease, I prefer surgery first.
And what kind of surgery would you prefer in this case, with multifocal disease of 35-year-old women with proven axillary 1 lymph node?
Well, if it is not possible to do conservative, it depends really on the
No, they are far away, believe me.
If they are far away, then if you were to remove them all, you have to do a mastectomy and consider reconstruction immediately.
Now, what kind of mastectomy? Would you do the skin sparing?
You can do a skin sparing mastectomy, provided the lesions allow, the anatomy is such that you can do that. If there is, obviously, in these cases where you have multifocal and multicentral cancer, you have to consider the possibility of familial inherited cancer syndrome. So really going back to the history and looking at the relatives, and sometimes you will be surprised. In my country, sometimes it is usual for patients to hide history, even from relatives. So really looking close at that thing worth doing, because you might, if you find an inherited syndrome, then you might consider even doing a contralateral prophylactic mastectomy,
So what kind of reconstruction would you prefer in this case?
That really depends on the patient's width, the size of the breast. But I think that in these cases, you can put an expander, like Becker's prosthesis, for instance, something that has been shown to be compatible with post-operative treatment, and it can be replaced by a permanent implant after the end of the therapies, and stretching to expand the cavity tissue to the desired volume.
Yeah, because she's going to have radiotherapy. That's why you prefer the expander. Yeah. Okay. Actually, we had to do the chemo first after this, because this was not her operation was not good, so she had a lot of lesions left behind. So we had to do the chemo. And this is the surgery area. It was clear, but in different areas, she had a lot of lesions. And here as well. So this is how she was before chemotherapy. The 3D MIP images. This is after chemo. They all disappeared. And this is the surgery bed. This is what you see here is the surgery bed. Yeah, I already asked this. So would you comment on planning her chemotherapy?
Yes, if I've seen well before, she had a HER2 negative disease on fish or cyst, right?
Yeah, her fish result was negative.
Was negative. And, but she was grade 3 with the Ki-67 almost high, around...
57. It was 57. Okay. 67 was 57. Yeah.
In that case, 4 courses of AC and then weekly paclitaxel or taxotere, other 4 courses could be, one of the preferred regimens for this case. And that could be the chemotherapy that I will give it to her.
Okay.
Excuse me.
Yes.
The other foci were biopsied or not?
Sorry?
I didn't understand. It's a multicentric disease. The other foci, the other lesions were biopsied?
Yes, we did, but not all of them. No, not all of them, but some two more lesions that were different than each other. We did the biopsy because she didn't believe, because she was believing that she had the operation and she has got rid of the cancer. But we told her that she had a lot of lesions.
The others were luminal B too?
Yes, all of them were the same. Before she came to us. Yeah. Yes.
Can I just say something?
Yeah.
I mean, in a case like that, if things were done properly, and she was investigated with an MRI scan and with fine needle aspiration biopsies of the axilla and true cuts of the primary lesions, then she could have had neoadjuvant treatment to begin with, in the hope that some of the tumor foci might completely dissolve, or even all of them, and even with the hope that the axillary disease could be eradicated as well.
Yes.
And because if you, in cases like that, if you do a sentinel lymph node and before neoadjuvant therapy, then you undermine the success rate of sentinel lymph node after neoadjuvant therapy. So it's a pity that it wasn't done to begin with.
Yeah, she had a terrible start, but after things got better. I will ask another question to you. Yeah. At this point, what would you prefer as there it is, the cine show of the multiple lesions that you can see. She has a lot of lesions. A lot of that you can. And this is after chemo that you see almost nothing.
Yes, we've seen that usually when we have a Ki-67 high and grade 3, we've seen a good response usually to the neoadjuvant treatment, but the reason that we give neoadjuvant treatment is normally for HER2 positive disease, triple negative disease, and in some cases in grade 3 disease.
Yeah, because it's with the luminal type cancers, it's low.
Yeah, luminal A and B, if they are locally advanced and will be a difficulty for a surgeon, then we give a preoperative chemotherapy, but not for the reason, for surgical reasons, but not because of the response.
Yeah.
Of the PCR.
But she might have some genetic mutations. So during the chemotherapy, we will have the answer of her genetic profile. So if she has, then she will have the opportunity to have both breast mastectomies at the same time. So sometimes neoadjuvant chemotherapy helps for that as well, with de-escalating the axilla.
Yeah, exactly.
And so at this stage, what kind? This was the only lesion left, only MR positive lesion left here. All the other lesions were disappeared. So, what would you do as for surgery for her now after the chemo?
Well, the lesion is far away from the nipple areola cancer. And it can be removed with conservative surgery. So if it is not palpable, it will need some localization therapy first. Some localization method with a Copan's guide wire or with a seed or intraoperative ultrasound, and then proceed to the lumpectomy and postoperative radiotherapy. But she hasn't had that.
Yeah, she might have. But she had a lot of lesions, so most of them are disappeared. Yes, please. Yeah. It's a multicentric disease.
She must have a mastectomy.
Well,
no. It all disappeared. That was just I was going to ask. She had a multicentric disease, a lot of lesions, and sometimes we see that MRI can be negative, and when we do the surgery, we find that it's still positive in cellular base. So would you be confident when
this
you do
this is a matter of debate. Obviously, the best radiological examination to assess neoadjuvant treatment effects on tumors is the magnetic resonance imaging.
But still,
sometimes, obviously, the tumor disappears from radiology, but you might have viable cells. And if it is just one tumor, then you just mark it before treatment, and you at least take a biopsy of that part, including the marker, to make sure that the tumor has completely responded. But if it is multiple tumors, this is more difficult to do, and it wasn't done. And as you said before, not even biopsies were done in all the different foci to begin with. So it isn't very clear. But there have been trials, and there has been research where surgery, excision, is not following complete response after neoadjuvant chemotherapy. There are many groups. There's one there's a couple in the United States, Johns Hopkins, and there is in Europe as well, in the Netherlands, and they have a protocol where they do guided biopsies of the areas where the tumors were, and if they're negative, obviously they take many biopsies, and they use the vacuum-assisted biopsy system. Then they follow up the patients without excising the breast, and it has been shown that it is quite safe.
Yeah, but with the vacuum-assisted biopsy, they do.
Yeah. So I mean, in this case, obviously, if it's a young patient, if she doesn't want to lose her breast, I think that she could get off with just the excision, radiotherapy, and very careful follow-up. I don't think that you can say that either is correct. Sorry? Yeah. No, it's actually there are level 3 trials now. They were level 3 a couple of years ago, and from many trials that have continued to mastectomy afterwards, the amount of residual tumor is less than 10%. So you can look at it as if it is a local recurrence in a way. If something grows up in a few months, you can you can do it. I think that in the future, you know, it is going to be more common to not do mastectomies after neoadjuvant in cases like
Hopefully.
that. Obviously, this is a...
Yes, please.
She's a 35-year-old lady. She will not be included in a trial. And the problem in multicentric disease will be there are the therapists after that.
Yes.
It's a multicentric disease. It's not multifocal.
Yes, it is.
A wide block procedure.
Yeah. The boost, you cannot give boost to all the breast. Yeah, yeah, but yeah, we did the mastectomy. Sorry. Her result was negative at the end. Yes, please.
In my opinion, with this breast and this amount of disease, unfortunately, no matter how good the response is, even if it is complete response in everything, if we don't have a clip in every single region, we cannot preserve the breast. Even if we had a clip in every single region, which we cannot do if we have 10 regions,
Yeah.
still we cannot preserve the breast. Because there isn't any oncoplastic technique to preserve the breast with 10 widespread lesions. So definitely have a need to study mastectomy.
Yeah.
After cleaning, we want to do downstairs axilla, which responded. But we couldn't preserve the breast.
Do you have an answer?
I think that for the argument's sake, you can say that tumor load is really what is important, you know. And if you have I mean, what would be the difference if you had this lady with a 10 centimeter tumor, which completely responded to neoadjuvant therapy? I mean, the facts we know is that she had some lesions. We don't know how many of them were biopsied to begin with, so we cannot assume that all of them were neoplastic. And if there is no good evidence of residual tumor load, why not preserve the healthy tissue? It's just an argument. I mean, why should you leave the breast in a lady with a 10 centimeter cancer that completely responds after neoadjuvant treatment, and cut the breast in a lady with a fifth of that tumor load that also responded?
Okay, thank you very much. We are out of time, but this can be a very good debate in another meeting, I think. A very hot debate. Thank you very much for attending today. I hope you enjoyed it. See you tomorrow.